Gives me a great deal of pleasure to introduce several exciting presentations. The first will be from Professor Kareem Mahmoud from Cairo University. It's entitled The Journey of Heart Failure Patient When the Diagnosis Begets More Complexities. Professor Kareem.
Thank you, my dear Professor Dr. Ayman Abulmagd. I'd like to thank Yava Cardigo board and Jack Case Report for this wonderful meeting. This is a case of a patient with worsening heart failure. So this is a 60-year-old male. He had mitral valve replacement 5 years ago before presentation and possibly due to a rheumatic heart disease. He is known to be hypertensive. However, his blood pressure on presentation was 100/80 millimeter mercury, and he was compliant to all his medication. The patient, the problem started one year ago with recurrent hospital admission due to heart failure function class 4 and rapid atrial fibrillation. Dr. Ayman, can you hear me?
Yes, we can hear you.
Yes, we can hear you very well. We can hear you very well.
Okay, thank you. In between admission, the patient, this patient with recurrent admission due to heart failure, in between he has severe still heart failure with the shortness of breath function class 3, and his ejection fraction is reported to be 35%. This was his ECG. ECG showed the left bundle branch block with atrial fibrillation of a rate of 90 to 100. And his X-ray showed a cardiomegaly with evidence of pulmonary congestion. As you have mentioned, the causes of this heart failure could be a mechanical valve dysfunction due to a paravalvular leak, thrombosis, pannus, or others, severe systolic dysfunction, coronary artery disease, arrhythmias. The patient already had atrial fibrillation, non-cardiac causes such as anemia, thyroid or CKD, or others. I first saw this patient in outpatient clinic, so we started to exclude the cause that precipitate the heart failure in this patient. So this was his old echocardiography. At first, we excluded the atrial fibrillation as the cause of worsening heart failure because his rate is more or less control of 90 to 100. So we searched for other causes of heart failure. This is his echocardiography that showed dilated left ventricular dimension with ejection fraction 35%. The mitral valve was well functioning. There was aortic valve disease in the form of moderate aortic stenosis with a mean gradient of 23 millimeter mercury and severe tricuspid regurgitation, which was functional, and elevation of pulmonary artery systolic pressure of 35 millimeter mercury. So we excluded the mechanical valve dysfunction as a cause of heart failure worsening in these patients. The severe systolic dysfunction can still be a cause of the patient symptom or could be another due to, as the patient we mentioned, he had other valvular lesions. For exclusion of coronary artery disease, the patient had a coronary angiography 1 year with a BCI to a stable lesion in the second obtuse marginal branch, which was a 60 to 70% stenosis, unlikely to be the cause of his symptom. And he had another coronary angiography 9 months later with that showed patent coronary stent. So coronary artery disease was excluded also. And regarding the labs, all his labs were more or less normal. Creatinine was 1.2, CBC hemoglobin was 11, normal thyroid function, and no other lab abnormality. So the non-cardiac causes also were excluded. So we are left with severe systolic dysfunction or other causes. And this was where his medication, he was on warfarin, clopidogrel, sacubitril, valsartan 100 milligram BID, carvedilol 12.5 milligram twice, amiodarone 200 milligram, furosemide 125 milligram once, and spironolactone 25 milligram. As you can appreciate, the patient was on good medical treatment. So still severe systolic dysfunction can be a cause, but we should search for other causes. So we repeat the echo. This is a reminder of the echo that was done 1 year ago. And you can appreciate the echo at the time of presentation with severe systolic dysfunction. The ejection fraction is less than 20%. We have, this is the shadow of echogenic shadow of the mitral prosthesis. And we can appreciate also the aortic valve disease with reduced excursion and thickened aortic leaflet. Also, the patient has a moderate degree of aortic regurgitation, as you can appreciate in this echocardiography. And this is the short axis view showing the reduced excursion and the thickened trileaflet aortic valve. The apical flow chamber view, you can appreciate also the severe systolic dysfunction that the patient had. The gradient across the mitral valve was okay. And the gradient across the aortic valve, the big gradient was 2.5. It's not significantly high on this resting study. So despite we concerned about the cause of worsening also left ventricular dysfunction over 1 year from 35% to less than 20%. So we decided to do more assessment for aortic valve using the dobutamine echocardiography. And surprisingly, the dobutamine echocardiography showed significant increase in the gradient across the aortic valve. And this was with fixed aortic valve area. So the peak systolic velocity increased from 2.4 meter per second to 4.1 meter per second. And the mean gradient increased from 15 to 38 with improvement in ejection fraction. This was the fixed aortic valve area. So we did a hard team for this patient, and actually he has a high surgical mortality. So we started to thought about the TAVR as a possible treatment for this patient. And we do more assessment of the aortic valve using the CT. As you can appreciate, there is no increased calcification. There is a spot of calcification of the aortic valve. And the possibility of that aortic valve to be aromatic or chromatic etiology can be. We started to assess the diameter of the aortic valve. The average diameter was 26.6 and the perimeter was 85.8, suggesting the possibility of implanting a large device. This was the dimension of the sinus of Valsalva and the sinotubular junction, tubular aorta. And also we assess the distance between the aortic annulus and the prosthesis because we don't want to our device to hinder the function of the mitral prosthesis. The height of the left main was acceptable, more than 11 millimeter, and his vascular axes were fine. As you can appreciate, there is no much calcification of his abdominal aortoiliac axis. And we choose the left axis, left iliac, because it's more straight and with absence of any calcification. The coronary angiography also were fine. There is no significant disease of all his coronaries with patent stent in the obtuse marginal fringe. So we started, we prepared this patient for a TAVR. The patient is not very good to withstand this procedure, and he was still in heart failure. So we did the procedure under general anesthesia. As we started the anesthesia, the patient developed hemodynamically unstable white complex tachycardia, and that was reverted using DC cardioversion. The axis, as we mentioned, was left common femoral axis using surgical cut down, and the right common femoral artery was used for 6 French sheaths for insertion of big tail for control injection with insertion of temporary pacemaker wire in the right common femoral vein. This is the control angiography using the big tail. As you can appreciate, the well-functioning mitral prosthesis, the aortic valve, and the temporary pacemaker wire in the right ventricle. We accessed the valve using the ambulance left catheter with a straight wire. And after passing the ambulance left wire, we exchanged this ambulance left into big tail guiding catheter, and we inserted the ambulance super stiff wire, and over the ambulance super stiff wire, we passed the valve, as you can appreciate here. Here we are trying to adjust the valve between the mitral prosthesis and the annulus. not to going deep and hindering the function of the mitral prosthesis. We weren't happy about the position of the valve, so we retract the valve and readjust its position. And here is the readjustment. And this was the deployment of the valve in two views. Again, here the valve was released. And we can appreciate that the mitral valve is well functioning, and we did a control angiography from a pigtail with no significant paravalvular leak. The axis was fine after closure of the left common femoral axis, and this was the final cine images to be sure that the valve is stable in its position and the mitral valve is also stable. After the procedure, the valve as seen by echo was stable in its position. There was no significant aortic leak, aortic paravalvular leak. As you can appreciate, we have also a severe impairment of LV systolic function. Here is the valve. Here is the aortic prosthesis valve. The gradient across the mitral prosthesis and the aortic prosthesis were acceptable. After the TAVR, we had immediate weaning from mechanical ventilation and intravenous vasopressors. Actually, we introduced the IV fluid with no worsening of heart failure to correct the blood pressure. We gave the patient a large amount of IV fluid, and the patient didn't experience any heart failure more. No evidence of heart block. Temporary pacemaker was removed after several hours. Actually, the patient developed the white complex tachycardia twice after the procedure. However, there was no drop of blood pressure. The patient can stand the tachycardia, and there is no evidence of myocardial ischemia. This was his ECG during the tachycardia and after the DC cardioversion. The patient we see that this patient would need ICD for this tachycardia, but we decided to do it later. This was his discharge medication, warfarin, clopidogrel, sacubitril, valsartan, carvedilol, amiodarone, and we reduced the diuretic dose, as you can appreciate, to torsemide 10 milligram, and the patient was fine on this dose with spironolactone. So this is the conclusion. We should search for the cause of heart failure worsening thoroughly, and aortic valve disease and heart failure carry the worst prognosis among these patients. TAVR offers a practical solution for these high cardiac risk patients, and also it's a multidisciplinary approach, and the key of success is a good preparation. And thank you so much.
Thank you very much. This is a very nice and interesting case with multiple issues. You presented it very well, and I think basically this is a case of severe aortic stenosis hiding behind the initial pseudo diagnosis of problem with the mitral valve. And I think you were quite prudent in searching for the aortic stenosis and diagnosing it, and then managing it accordingly. Did I see the ejection fraction improve afterwards?
Slightly. Unfortunately, this patient was done before the COVID era, so till now we didn't have post TAVR echo. However, the echo that was done after the TAVR, the ejection fraction was slightly improved, and the follow-up, the clinical follow-up with the patient was fine. However, we don't have still a recent study for this patient.
Okay, Hani is asking the questions I wanted to ask, which are both related to the warfarin and the clopidogrel, because apparently the PCI was done like a year before, and I assume it was a non-infarct case. So really, there really probably shouldn't be a reason for the patient to be on clopidogrel with warfarin for such a long time, as it would increase the risk of bleeding. And Haney was also asking about stopping the warfarin during the TAVR procedure.
I thank you, Dr. Hani, for both questions. I already saw them. Regarding the interruption of warfarin before TAVR, actually it was done, and we shifted the patient on low molecular weight heparin till the end of procedure, and the indication of warfarin after the procedure was mainly for the mitral valve prosthesis, mechanical mitral valve prosthesis. Regarding second question, you're completely right. We scheduled this patient this patient on warfarin, and we excuse me.
Can you continue, please? I didn't hear you.
Yes, you are completely right regarding the parachute.
Indication.
Excuse me, Dr. Ani. I can't hear you. I can't hear you well.
Kareem, continue your rationale so we can understand.
Yeah, but the clopidogrel.
I saw your second question, Dr. Hani, is regarding the rationale of clopidogrel on top of warfarin. Actually, yes, this should be stopped. However, the patient didn't have any bleeding episodes, so the initial plan was to start patient on clopidogrel and warfarin, and to stop the clopidogrel later on and continue on warfarin.
Also, Julia has a question about post amiodarone use.
I was thinking about amiodarone. He had amiodarone 200 QDS, meaning 4 times a day, and I was thinking that
no, it's once daily. No, sorry, it's once.
Is it twice a day?
No, it's once daily. It's loaded, and then it's once daily. It's he started on amiodarone once daily.
I was thinking that was immediately post-TAVR.
Yes.
Okay.
Amiodarone, yes. It's the patient was on amiodarone before the procedure because he had a recurrent episode of atrial fibrillation during the last year, and we continued amiodarone, knowing that it is not the best option. But we decided to continue amiodarone to suppress the atrial fibrillation and the ventricular arrhythmia or wide complex tachycardia that the patient suffered, and planned for an ICD later on. But however, the ICD wasn't done till now.
Definitely. I was thinking, because usually 48 to 72 hours post-TAVR, we can see starting from first degree up to even second degree heart block. That's why I was asking about the amiodarone.
Especially he is on carvedilol also.
Yes, this is a very good point. The patient was on temporary pacemaker after procedure for, let's say, 24 hours. However, the main indication for amiodarone, because he had a recurrent wide complex tachycardia after the procedure, so we needed to suppress this tachycardia because we're afraid of hemodynamic instability in this low ejection fraction. So we decided to continue amiodarone and close follow-up of the patient.
Dr. Kareem, it's a wonderful case, and really you managed to move through the diagnosis and then through the management in an excellent way, particularly implanting a TAVR in a mechanical mitral valve prosthesis. That's quite a challenging situation, but you managed to do it excellent. My concern is about the wide complex tachycardia. And should we think of an ICD for that issue? Because it was recurrent and it was very frequent after even the TAVR. What do you think about this issue?
Before you answer, Kareem, I'd like to add to Professor Khaled that could it be an ICD or CRTD, because it is a heart failure case. It is a very important question, Professor Khaled, and I think we need to know the opinion of Kareem and maybe the other panelists.
Okay, thank you for both. I already mentioned the need for ICD. Regarding the CRT, the patient already had a left bundle branch block. However, it was in atrial fibrillation. So it can be done now to place a CRT in patient with atrial fibrillation. Regarding this patient, I would consult really an electrophysiologist. If we upgrade the ICD, definitely he needs ICD. But regarding the need of CRTD, I would consult an electrophysiologist about the indication of CRT, taking in consideration that the patient had atrial fibrillation.
Well, can I ask questions if you have time, Kareem, about the aortic regurg?
Yes.
This patient has pre-operative moderate aortic regurg.
Yes.
And we know that post-TAVR aortic regurg has a poor prognosis. So how can we differentiate between residual aortic regurg from the original disease or post-TAVR aortic regurg that is risky and prognostically not very well?
Actually, the aortic valve disease can be a combination of aortic stenosis and aortic regurgitation. And the aim is to solve or correct the aortic valve disease. The most important issue is the degree of aortic regurgitation or paravalvular leakage after TAVR. More than mild aortic regurgitation would be associated with worse prognosis. So every effort should be done to correct aortic stenosis with and eliminating any degree of aortic regurgitation. The acceptable aortic regurgitation or paravalvular leak should be less than moderate, should be mild, because more than that would be associated with the worse prognosis.
Also, that implanting the valve. Now, the aim of treating the aortic valve, I think you showed that this is actually, although it seems like it's a mild to moderate aortic stenosis, it's more severe because of the impaired ventricular function. And you would expect that to get the real benefit from the valve, I would expect the ejection fraction to actually improve afterwards. And unfortunately, we do not have the follow-up, because that improvement would impact subsequent decision-making regarding CRTD, for example. Maybe the exocystosis, the ventricular arrhythmias might need an ICD. But if the ejection fraction improved, then it would just be an AICD rather than CRTD. So,
totally agree, Dr. Ayman. Totally agree, Dr. Ayman. Totally agree.
Excuse me?
Totally agree, Dr. Ayman.
So I think a final step, because to actually determine the benefit of the TAVR regarding his management, it's important to show, if possible, that the patient got a benefit in the form of improvement in ejection fraction, improvement in the heart failure symptoms. And perhaps you might be able to search for this data and perhaps inform us at some point in time.
Sure.
Julia, do you think that the 3D echo will have any role in managing such a case in the decision making? It will make difference to you, the 3D echo here in such a case?
So, recently, thank you, El Said, for this question. I think pre-operative planning is very important. You mean, I guess, for the pre-operative planning, isn't that? And sometimes what's happening is here, it depends on the experience. Here, for example, they are quite based on CT. And in order to pre-plan the LVOT not to have a significant obstruction, if they find the CT values that they're inconsistent to prepare the valve, then they will have a TOE intraoperatively and make the decision on the table. So it's always important for us to be standby. And sometimes, we have seen cases that we want the pre-op TOE to help us make the decision.
It's okay.
Okay, I think we probably have to move on. Thank you very much. It's a very exciting case. Thank you, Professor Kareem. As always, a very interesting and provocative case, managed well. Thank you very much.
Thank you so much.